You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites on iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now let's go beyond the abstract. Hello and welcome back to another episode of Beyond the Abstract. We appreciate you stopping by. Today we are talking to Dr. Joao De Aquino about his article, The Role of Childhood Trauma in Chronic Pain and Substance Use Among Individuals Receiving Methadone Treatment for Opioid Use Disorder, which is featured in the current May-June issue of the Journal of Addiction Medicine. In this episode, Dr. De Aquino shares insight into the correlation between childhood emotional abuse and pain and substance use in adulthood. He also discusses potential mechanisms underlying the relationship between emotional abuse and pain outcomes and substance use patterns, as well as how the findings from his study can inform clinical management of pain and SUD treatment. All right, let's take a moment to learn a little bit about our guest today. Dr. Joao De Aquino is an assistant professor of psychiatry at Yale School of Medicine and assistant director for research affairs at the Clinical Neuroscience Research Unit. He also directs the Pain and Addiction Interaction Neuroscience Lab. And Dr. De Aquino is an addiction psychiatrist and physician scientist whose NIH-funded research focuses on the intersection of chronic pain and substance use disorders. He combines behavioral pharmacology, psychophysical techniques, and clinical trial methods to develop novel therapeutics for pain and addiction. His work has established a translational human laboratory platform for experimental therapeutics at the pain-addiction interface, and this research examines the balance between analgesic efficacy and abuse liability of non-opioid analgesics, integrating mechanistic studies with clinical research in complex patient populations that are often excluded from traditional trials. Dr. De Aquino's research has been supported by K23, R21, and R01 awards from the National Institute on Drug Abuse. He's an associate member of the American College of Neuropsychopharmacology and chair of the research committee of the American Academy of Addiction Psychiatry, and associate editor for Drug and Alcohol Dependence. All right, now let's get into today's episode with Dr. Joao De Aquino. And we'd like to hear about why addiction medicine. You know, the folks that are in it seem to be very passionate about it. So what led you to this particular field, and what have your experiences been like, throughout the course of your career?
Oh, thank you for having me. What drew me was the intersection, the place where pain and addiction meet. So early in my training, I kept encountering the same patients over and over, people living with opioid use disorder were also living with severe chronic pain. And what struck to me was that our healthcare system had essentially split that person in two. The pain clinic would treat their pain, but was wary of their addiction, and the addiction treatment program would treat their addiction, but had little to offer for their pain. So I was treating the whole person. And that's what I've tried to build my career around. I direct the Pain and Addiction Interaction Neuroscience Lab, or the Pain Lab at Yale. And our mission is to understand how those conditions interact biologically and clinically, so we can develop treatments that address both at once instead of forcing patients to choose which half of themselves receive care. And what keeps me here is the combination of these two things, the science, which I think is thrilling. We're learning how experience gets written into the nervous system, and the privilege of the work with patients, the work itself. When someone trusts you with incredibly challenging things that happen to them and lets you help, I find that very rewarding.
Yeah, amazing. And I want to dive right into this article, and you touched on it here just a little bit about what you're working on, but can you describe for our listeners, the relationship between childhood trauma and severity of pain, alcohol consumption, and cannabis use in adulthood, and maybe talk a little bit about what led you to assess these relationships in patients being treated with methadone?
Sure. Let me take the second half first, because I think it explains the whole study. We chose people receiving methadone for opioid use disorder deliberately. This is a group where the endogenous opioid system, the brain's own pain and reward machinery, and the system that methadone acts on, is already front and center. We knew from the literature that childhood trauma is remarkably common in people with opioid use disorder, that it raises the risk of chronic pain in adulthood by something like 50%. And that's tied to earlier opioid use and even return to using opioids during treatment. But very few studies have put trauma, pain, and substance use together in the same frame, and specifically in people who are receiving OUD treatment, and that was the gap. So we studied people receiving methadone in the New Haven area. We measured childhood trauma with the childhood trauma questionnaire, pain with an assessment tool called the Brief Pain Inventory that captures both the severity and how much pain interferes in daily life, and also recent substance use for about a month. And what we found is that within this population where trauma is already common, the degree of trauma mattered. So higher trauma scores correlated with greater pain severity, with more alcohol consumption, and with earlier initiation of cannabis use. That cannabis relationship was actually our largest effect. So people who use cannabis also reported significantly more emotional abuse, sexual abuse, and physical neglect than those who didn't. I want to be precise about the strength of these findings. These correlations were small to moderate. So trauma isn't the whole story of anyone's pain or substance use. But to me, the fact that a signal survives at all in a group where nearly everyone has some early life adversity, that tells you the dose of trauma is probably doing something real and worth paying attention to. And notably, we did not see significant links to heroin, tobacco, cocaine, or stimulant use. Partly, I think, because our sample was stable enough in treatment to volunteer for research.
You did mention emotional abuse as one of those factors, and I wonder, you said childhood emotional abuse was a strong correlate with pain and substance use in adulthood. What are some of the potential mechanisms that are underlying that relationship between emotional abuse and pain outcomes and the substance use patterns that you're seeing?
So emotional abuse, which, if you look at the assessment tools, means being demeaned, called names, made to feel unloved or worthless, was the trauma type that showed up most consistently across our outcomes, which were pain severity, pain interference, and substance use, specifically alcohol use. And that's not just our small sample. Prior work has singled out emotional abuse as a primary predictor of alcohol use disorder severity. So the question is why? Why is emotional abuse, of all things, carrying that weight, right? And I point to two broad mechanisms. The first is neurobiological. There's substantial evidence that early life adversity reshapes the endogenous opioid system and the stress response system. We're talking about epigenetic changes to opioid receptors, altered cortisol profiles, heightened pain sensitivity, and even measurable differences in brain structure, like reduced volume of the hippocampus, which is an important part of the limbic system. In one randomized double-blind study, adults with childhood trauma were more sensitive to the pleasurable effects of morphine and less sensitive to its aversive effects. Our old group found the same pattern with delta-9 THC, the primary psychoactive ingredient of cannabis, in people with opioid use disorder. Trauma was associated with a blunted response to THC's aversive effects. So different drug classes, among different drug classes, early trauma seems to turn up the reward and turn down the brakes, if you will. And that fundamentally changes the risk-benefit math of using a substance. And it can plausibly change how pain is processed too, since we're talking about the same system, the same opioid and reward systems. The second mechanism is psychological and developmental. So children in emotionally abusive homes often don't learn healthy ways to regulate stress. They don't have models for it. So when they are older and overwhelming emotions hit, a substance becomes eventually the coping tool that's actually available. And that's what's often called a self-medication pathway. In adolescence, we know it's a sensitive period for the reward system. using substances early, which trauma predicts, isn't neutral. Early initiation is itself a risk factor for developing a substance use disorder. So you get this chain of people experience emotional abuse, disrupted emotional regulation, and an altered opioid system, and then early substance use to cope in escalation. And pain, and by pain, I mean both physical, emotional pain, and substance use aren't two separate problems here. They're kind of true branches growing from the same root, if you will.
Wow, it's really fascinating. I wonder now, looking at the findings from the study, how do you think that the findings about childhood trauma, pain, and substance use can maybe inform clinical management of pain and treatment of SUD? And kind of as another part to that, what role do you think that trauma-informed approaches and integrated care models kind of play in treatment for individuals with this childhood trauma and OUD?
The core clinical message is that trauma and pain deserve to be assessed as routinely as we screen for substance use. Right now, as I said, care is fragmented. Addiction programs rarely screen systematically for childhood trauma or chronic pain. And conversely, pain clinics rarely screen for addiction. That is changing. But each system sees, in general, with exceptions, each system sees a slice of the person, and very few see the whole person, and patients tend to fall into that gap, which is exactly why returns to use, one of the reasons why return to use tends to happen so often. As I mentioned, there's even neuroimaging work linking childhood maltreatment to limbic brain changes and through those to more severe relapse. The good news is that the tools already exist to assess trauma and pain. And the tools we use in this study, for example, they take a few minutes. So the clinical implementation to me has three layers. First, screening at intake built into the standard assessment. Second, matching patients rather than a blanket treating them. So screening is about identifying who benefits from trauma-focused therapies and from pain-focused interventions. And third, the sequence of events matters as well. You stabilize the OUD treatment first, and only then moving to trauma-focused work when someone has the footing to tolerate it. And doing it in the wrong order can destabilize people. And when you do find something, integrated models give you somewhere to send people. So there are stepped care trials showing that you can integrate pain management into OUD treatment. We have evidence-based interventions such as mindfulness-oriented recovery enhancement, which was built for co-occurring chronic pain and substance use. There are also trauma-adapted cognitive behavioral therapies. And even web-based programs. There's something called Empowered Relief that have been tested in patients receiving methadone or buprenorphine. The point is that trauma-informed integrated care isn't something aspirational or vague ideal. It can be a concrete framework and in a concrete workflow of screening people, matching them, and then providing the treatment in a sequence that makes sense. And of course, screening only works if you build a safe enough environment for honest disclosure. Otherwise, you miss the very thing you're looking for.
I wonder too, looking even a little bit broader, this study focused primarily on individuals in OUD treatment, but I wonder if you can speak to how the findings might apply to individuals with other SUDs or co-occurring SUD and mental health conditions.
That's a great question, and I'd answer this at two levels. One, what generalizes in principle, and where we have to be humble and more evidence is required. What generalizes the mechanism, the neurobiological and developmental pathways we've been discussing, altered stress response systems, altered reward processing, disrupted emotional regulation, those are not opioid specific. They're general vulnerability mechanisms. And that's consistent with a large literature linking childhood adversity to alcohol, cannabis, tobacco, and stimulant use disorders, and to depression, anxiety, and post-traumatic stress disorder. So the core principle that a trauma history shapes how someone experiences this stress and how they cope, that should apply well beyond opioid use disorder. And there's an important point about co-occurring mental health conditions specifically. In our study, we assess trauma history rather than current PTSD. And those are different because not everyone exposed to trauma develops PTSD. But the neurobiological effects of early adversity appear to persist regardless of whether someone meets criteria for a psychiatric diagnosis. And that suggests that trauma history alone, even without a formal PTSD or depression diagnosis, can help identify people at higher risk for pain and substance use challenges. If our clinicians treating any co-occurring substance use disorder and mental illness, that argues for making trauma and pain part of the routine assessment, not something you look for once a psychiatric diagnosis is on the chart. And then where I'd be humble is the specifics. So our particular findings, emotional abuse as the standout correlate, the strong cannabis initiation signal, the null findings for heroin and stimulants, that came from a stable sample receiving therapeutic doses of methadone in one region of the country, in a population with, say, stimulant use disorder, or in people earlier and less stable in treatment, the pattern could look quite different. So I'd frame it this way: the overall direction of clinical implications, screening for trauma and pain, integrate care, I'd say that almost certainly generalizes. The exact correlation should be treated as hypotheses to test in each new population, and they're far from settled.
You've gone over a lot of these findings. It's really incredible, but I wonder what kind of questions came out from this study, and what kind of research studies in the future do you think might be able to address some of the questions that came about and bring about some answers or solutions?
Yeah, so our study was cross-sectional, so that's a snapshot, and that's the main limitation. And studies like this often raise more questions than settle them, because that's what an exploratory study should do. The first and biggest question is directionality, the cause. We see that trauma, pain, and substance use cluster together, but we can't say from a cross-sectional design where trauma drives pain and use, and whether they reinforce each other over time, or whether a third factor drives all of them. The ideal design is longitudinal, a prospective cohort following people over time, ideally before treatment, so you can watch the sequence of events unfold. The second question is mechanism. We've inferred a lot about the endogenous opioid system, stress systems, and emotional regulation, but our study measured none of that directly. It was self-report. So I want future work to add biomarkers, which we do in our lab. So neuroimaging, physiological measures, stress hormone markers, laboratory pain testing. And again, these are things we do in our lab. And combining controlled lab studies with real-world clinical populations. That's how you move from these things correlate to here's a likely pathway or the likely explanation. The third question is the one that matters most for patients, which is, does acting on this actually help? It's one thing to show that trauma correlates with worse outcomes. It's another to show that screening for it and delivering integrated trauma-informed pain and addiction care improves trauma symptoms, pain, and substance use. And that calls for randomized trials of these integrated interventions. And I want those studies to be more comprehensive than ours, larger samples, more diverse settings beyond one region, and better characterization of the trauma itself, including timing, duration, severity, which we couldn't capture. So longitudinal cohorts for causation, mechanistic studies for the how, and intervention trials for what we do about it. That's what I would say.
Well, doctor, as we come to the close of our show here, we have a tradition, as I like to tell our guests, and we always ask for a little bit of advice and wisdom. So shifting gears just a little bit, I would love to hear what advice you might offer to not only your younger self, maybe when you were just getting into this field, but maybe, those interested in becoming an addiction medicine clinician or practitioner. What kind of words of wisdom or knowledge would you like to share with them, and do you think they should know?
Sure. I would offer, I would say first, resist the fragmentation of your patient. Medicine will constantly pressure you to specialize and see the quote unquote addiction problem or quote unquote pain problem or the quote unquote trauma problem as separate. And we do need deep expertise in each one of these areas. We do need specialists. But your patient has one brain and one life story. And these conditions are deeply intertwined in both. So I would say stay curious about patients' lives and their stories. And if you do that, they'll tell you what they tell you might explain the pain to substance use and even the patient's relationship with the healthcare system itself. Second thing I would say is, get comfortable holding science and compassion in the same hand. The neuroscience of trauma is one of the most destigmatizing bodies of knowledge that we have. Once you understand that early adversity can essentially recalibrate someone's opioid and stress systems, making drugs feel better and their downsides feel weaker, the question stops being, why won't this person just stop? And it becomes, how do we treat someone whose brain was shaped by experiences they never chose? And that reframe changes how you practice, and I think patients feel the difference. And the third thing I would say to my younger self, as you mentioned, and to anyone considering this field, I would say that the field needs you, and I think that the field will reward you. Addiction medicine is where some of the most important and most solvable problems in all medicine live. The treatment gap is enormous. The science is moving fast. And few specialties give you the same chance to change the entire trajectory of a person's life. And often, not just their life, but their whole family's lives. So I would tell my younger self to worry less about picking the safe path and more about following the problems that genuinely move you. And this problem never stopped moving me.
Love it. Great words of wisdom. Thank you so much, Dr. De Aquino, for stopping by today and talking with us.
Thank you. My pleasure.
Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. And remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.